Good morning, everyone, and welcome to session 2. You are now in Bringing Measure Accurately, Training Your Team, a Target BP Watch Party Toolkit demonstration. CME credits are available with the session, and we'll have information on how to do that and how to claim those CME credits after the sessions. Now, I would really like to welcome our panelist, Allison P. Smith. Allison is the Program Director of Target BP for the American Heart Association and the American Medical Association. Please let us know in the chat box what organization you're with and where you're from. We're expecting people from all over the New York State today. And please make sure that you select all panelists and attendees so we can see your message. If this is not the breakout session that you're looking for, please message the panelists so that we can get you in the right place. Again, without further ado, I'd like to welcome Allison. Good morning, Allison.
Thank you, Michelle, and I really appreciate the opportunity to be with you all here today across the state of New York. I'm here in dreary Chicago, but parts of my family and my heart are across New York State. My mom and my grandparents are from Syosset, Michelle's hometown. My parents now live in Asheville and Chautauqua County at the other end of the state, and my husband's family is all from Binghamton. So we're just delighted to hear all the wonderful things that are going on across the state of New York with regard to hypertension control. So today we have sort of a dual purpose in this breakout session. We're going to be multitasking. One is to focus on strengthening our knowledge and skills around blood pressure measurement and the importance of its accuracy, the step 1 of the MAP framework that you heard about in the opening session today from Dr. Breakout. And the second purpose is really to demonstrate the use of this Watch Party Toolkit in the spirit of see one, do one, teach one, so that you can then take this resource home and use it with your care team to strengthen blood pressure measurement training. So with that, we're going to dive in here. I'm going to start with a little bit of housekeeping. I know we're all Zoom experts by now at this point in the pandemic, and we're going to be using the Q&A and the chat function. If you could use the Q&A function to ask questions, and that way it'll be easy to identify those. If someone else asks a question that you share, give it an upvote and it'll raise to the top of the pile. And then we'll also ask you to use the chat to introduce yourself, make comments. But I also want you to keep your eyes on the chat as the program unfolds, because my colleague, Caitlin Dean, a fellow nurse and senior manager of clinical operations at the AMA, is going to be dropping links in the chat for some of the resources that are mentioned along the way. So again, we're trying to model how we can also leverage the technology and that you can do the same when using these resources in your healthcare organization. So for today, again, our dual agenda, I'm going to provide a brief overview of the toolkit and give you a preview of the educational content that you can use and customize to meet the learning needs of your care team. The learning objectives that are covered by those resources are outlined here, including describing the accuracy, the importance of blood pressure measurement accuracy, some of the factors that can come into play, both from the patient, the staff, or the system of care that you have in place that can impact the accuracy of measurement. And then similarly, identifying opportunities where you can really strengthen the skills and the care processes in your healthcare organization. And then also thinking about how these concepts translate to self-measured blood pressure and the importance of equipping patients with those exact same skills that we want our staff and our care teams to have. We'll talk a little bit more about how to leverage the resources in this toolkit. Again, it's highly customizable, and then make sure we have time for Q&A. Again, you're welcome to use the Q&A function. We'll also have time at the end where you can raise hands, especially looks like we have 20-ish folks, so we can certainly have time for conversation at the end. With that, diving into the contents of this toolkit, which you will all receive following this session, you'll receive an email with the evaluation, with the instructions to claim the CME and CE credit associated with this, as well as the resource itself. The resource itself contains the learning objectives that I just described, some tips on logistical support. particularly, things like the event flyer. We have some templates that are ready to use if you want to advertise that within your healthcare organization, if you're going to host a similar training. We discuss some of the key roles in conducting an event like this, who would moderate, if you want to have a subject matter expert on hand, how to organize some of the technical support if you're using a video platform like this. We also have an overview of the content available, the video segments that you can use all or some or none, some of the handouts that are really helpful in translating this training into practice, both in terms of equipping your care team with tools that will help them use the skills consistently with every patient every time, but also resources that you can equip your patients with to reinforce, particularly in the context of self-measured blood pressure use. We also have a moderator guide embedded in the kit, with all sorts of poll questions, test questions, discussion questions. We'll show a few of those today, just to give you a flavor of how you might leverage the technology and the questions. Obviously, you can always invent your own, but we wanted to give you many menus from which to choose. And then we'll also, the kit also highlights how you can use this resource to advance your recognition through Target BP, particularly if you're familiar with the Silver and the Gold Plus categories that emphasize evidence-based blood pressure measurement techniques and activities. And by training your staff and testing their skills in measurement and blood pressure measurement every 6 to 12 months, you will satisfy 2 of those 6 criteria right off the bat. So that was one of the reasons for creating this resource, to support and advance your recognition in the Target BP program. We also have some tools for attendance tracking, skills testing, and then ultimately the guidance on claiming the enduring CME and CE credit that's associated with this resource. So there are lots of details in there, but that's just a high-level overview of what you will find. So we're going to start with an example of one of the poll questions that we have in the toolkit, and I would encourage you all to respond to this poll. So how often should healthcare professionals be trained and assessed for competency in blood pressure measurement? I appreciate your answers here: every 6 to 12 months, every 2 years, when they're initially hired or oriented, or upon completion of their initial health professional training. I'll let you answer for a minute here. Looks like we could use a few more answers here. All right. And so it looks like the majority of you chose the correct answer, which is the guideline recommendation is for health professionals to be trained every 6 to 12 months in blood pressure measurement, which I think some of us find surprising when we learn that fact for the first time, perhaps, because it's something that it is one of the first skills we learn in our training, whether it's medical school, nursing school, medical assistant training, and it's something that we do every single day. But that's one of the reasons why I think it's so important. Whoops, I think I need to share those results. I don't know if you guys saw those. Sorry. It's so important, to repeat that and refresh that training, because there's so many little things, as you'll see in the training materials, that can contribute to significant errors that make the difference between a diagnosis of hypertension or not, the reason to intensify treatment or not. And so it's a really critically important skill. So that's just an example of one of the poll questions that are embedded in the kit that can help make the training interactive and give you a little more insight into the knowledge, skills, and priorities for your care team. So next, this is an overview of the entire video content library that's available in this module, that starts with introduction, goes through a few different topic areas of blood pressure measurement, an overview, a deeper dive into validation and calibration of devices, a deeper dive into actual measurement technique, and then an overview of resources and tools to support improvements in practice and to support patients. And lastly, there's a Q&A section. So you can pick and choose from these video segments. Today, I'm going to share with you the three that are highlighted in parts 2, 3, and 4, and that will be the sort of the meat of the clinical content today. And then when those conclude, we'll dive a little bit more into your questions, both about the clinical content, and I'll highlight a few more features in the toolkit for your use and thinking about how this might be helpful in your own healthcare organization. So with that, I'm going to move to the video content. We're delighted in this video to feature three colleagues of mine from my AMA role. Kate Curley is the Director for Chronic Disease Prevention at the AMA. She's a family physician and leads off in this presentation. Linda Murakami and Taylor Turner are both do tons of work working with healthcare organizations across the country in their practice facilitation work as nurses and their program manager and improvement specialist role. So you'll hear from each of them during this presentation. So with that, I'm going to start the video and y'all can sit back and take that in, and then we'll regroup in a live conversation following this video presentation. So with that, I will start the video.
Thank you so much, Allison. Next slide. So I'll dive right in by sharing the exciting news that Linda, Taylor, and I have no conflicts of interest to disclose. Next slide, please. And briefly, our objectives for our presentation today. First of all, I'll talk about how accurate blood pressure measurement really provides this crucial foundation for proper diagnosis and management of our patients with high blood pressure. We'll talk through in some detail the factors that can make blood pressure readings inaccurate, and importantly, help you identify strategies to overcome those factors. We'll share with you how you can use measure accurately and patient measured blood pressure tools to identify opportunities to improve blood pressure measurement accuracy in your organizations. And then we'll talk in some more detail about self-measured blood pressure, a really hot topic right now. Next slide. Now, I suspect because you have joined us on this webinar today, and thank you for being here, by the way, that you're already pretty bought into the idea that hypertension care is really crucial, that we really need to focus on the quality of care in this area. But I want to do a little bit of level setting, and I really like this slide, which we borrowed from Hilary Wall, a senior scientist at CDC's Million Hearts Initiative. And what she's done here is she's laid out common risk factors that we're all very familiar with for heart attack and stroke. So we see blood pressure control, cholesterol management, physical inactivity. And what we can see here is the relative contribution that each of these factors makes towards preventing heart attacks and strokes. And you can see that far and away, blood pressure control really takes the cake here, right? So this is the single factor that is most influential in preventing heart attacks and strokes in our country. And so that's not to say that cholesterol management and tobacco cessation are not important, they're crucial as well. But the single strongest lever that we can pull to prevent heart attacks and strokes in our country is to improve blood pressure control. Next slide. So how are we doing as a country when it comes to blood pressure control rates? So this slide shows NHANES data for the past 20 years. And here we're using a blood pressure control definition of 140 over 90 millimeters of mercury. And what you can see is that going from about 1999 to 2010, our country was pretty steadily improving in terms of blood pressure control rates. So we went from about 32% of people with hypertension having their blood pressure at goal, all the way up to about 53% of people reaching their goal. And then we sort of plateau for a number of years there. And then, unfortunately, more recently, we're starting to see a decline in blood pressure control rates. Actually, this slide is now a little bit out of date because about 3 weeks ago, we had a new publication come out in JAMA looking at the blood pressure control rates with NHANES data in 2017 and 2018. And what we saw was that the national blood pressure control rate had actually further dipped to 43.7%. So we're going in the wrong direction when it comes to blood pressure control. But I think this represents an opportunity, and really I hope it serves as a clarion call to all of you on this webinar with us. I hope you all will commit to redoubling your efforts at improving blood pressure control rates along with us. Next slide. So thankfully, there are successful evidence-based approaches that we can use to improve blood pressure control. So for example, the AMA's MAP BP Quality Improvement Framework. So MAP stands for M, measure accurately, really the focus of our webinar today, really the idea that we need accurate blood pressure measurements in order to correctly diagnose and manage our patients. A is about acting rapidly and really avoiding therapeutic inertia and making sure that our patients get their treatment in a timely fashion. And then P is also crucial. It's about partnering with patients, really supporting our patients and adhering to their treatment plan, as well as self-managing and self-monitoring their condition. And we know that all three of these M, A, and P components are critical for improving blood pressure control. But as we've noted, we're really going to focus on that measure accurately piece today. Next slide. And I just want to quickly note that the MAP framework is effective and evidence-based. So we have studied it in multiple healthcare organizations. And for example, that publication on the right, we studied the MAP approach in 16 practices. And what we saw was that blood pressure control improved from 66% at baseline to about 75% at 6 months. And that improvement actually persisted at 12 months. So all of this just to say that we do have effective evidence-based approaches of improving blood pressure control. MAP is a really good example of that. Next slide. And the cornerstone, really the foundation for the MAP framework is this measure accurately piece. Next slide. So why does accurate measurement matter so much? Of course, accurate measurement is critical so that we can make sound diagnostic and treatment decisions with our patients. So imagine if we underestimate our patient's blood pressure. Then we run the risk of failing to prescribe or treat our patients, putting them at increased risk for heart attack and stroke. On the other hand, if we overestimate our patient's blood pressure, then we run the risk of overtreating them and potentially causing medication-related adverse events. So getting those accurate numbers is really critical. But it's easy to fool ourselves into thinking that, you know, we're good at this isn't that complicated, because we take blood pressure measurements all the time. It's actually the most commonly performed procedure in the ambulatory setting. So we do this a lot. It's easy to take blood pressure measurement for granted. But unfortunately, many office-based blood pressure measurements are taken with poor technique, leading to inaccurate blood pressures. And then you layer on a number of other challenges. So blood pressure variability actually exists in everybody, right? Our blood pressure varies from moment to moment. My blood pressure is varying just over the course of giving this talk. And then we also have different blood pressure phenotypes, like white coat hypertension and masked hypertension, where our patient's blood pressure behaves differently in the office than it does outside of the office. And so when you put all of this together, what happens is that a single office-based blood pressure measurement in the end correlates poorly with a patient's true blood pressure overall. And so we struggle to get that accurate measurement that we need to, again, diagnose and manage our patients properly. Next slide. So when it comes to technique, this is more complicated than we tend to remember. So this slide right here is depicting a systematic review where they looked at a variety of potential sources of blood pressure measurement error. And they checked to see whether or not performing one of these steps wrong actually influences the blood pressure measurement. And what they saw was that 27 of these factors, if performed improperly, can actually bias that blood pressure measurement. 27 different things that we need to do properly in order to get an accurate blood pressure measurement. So it's more complicated than we tend to remember, and that technique is really, really crucial. Next slide. And then even if we use perfect technique to take a single blood pressure measurement, that's still actually not enough. And part of that is because of the alerting response. So the alerting response is this phenomenon where when our patient first comes into the office and we measure that first blood pressure, it on average is going to run higher than if we wait a little bit and we repeat the measurement about 5 minutes later and then a few minutes after that. And so if we just take that single first measurement, on average, we're going to be overestimating our patient's blood pressure a bit. And then to make matters more complicated, doctors are the worst. And I can say this because I am a doctor. Physicians are actually the worst people to be taking a patient's blood pressure measurement. So that alerting response tends to be even stronger with physicians than it is with other members of the care team like nurses and medical assistants. And so it's really crucial that we take the right number of blood pressure measurements and that we have the right people doing this measurement. Next slide. So I just laid out a bunch of the factors that can go wrong, sort of the different complications that can happen with blood pressure measurement. We do, however, have a lot of recommendations that provide evidence-based guidelines in terms of how to do accurate measurement, how to get proper measurements for blood pressure. So you can find some of this guidance in the 2017 ACC/AHA multi-specialty guideline for the prevention, detection, evaluation, and management of high blood pressure in adults, essentially the ACC/AHA hypertension guideline. So there's a lot of information about accurate measurement there. Even more detail can be found in the AHA's scientific statement about the measurement of blood pressure in humans. This is a fantastic resource. We use it all the time. A lot of the content in our talk today comes from this resource. And I'll just note, there are some tables in that scientific statement that I find really helpful as sort of quick reference tools about the components of accurate blood pressure measurement. And then another guiding document that we'll reference today is the joint policy statement from the AHA and the AMA about self-measured blood pressure monitoring at home. Next slide, please. And I want to take a moment here to introduce the concept of self-measured blood pressure, or SMBP, because we're going to reference it a lot in the talk today, and we're going to have a section about it later in a lot more detail. As I noted, it's really become sort of a hot topic in the face of the COVID pandemic when we're thinking a lot more about virtual care for our patients. So to define it, self-measured blood pressure, or SMBP, is when we take blood pressure readings outside of the clinical setting. And most commonly, this is done by the patient taking their own readings at home using their own device, so home blood pressure monitoring. SMBP is crucial for classifying and diagnosing patients correctly, so we should be using out-of-office measurements to correctly diagnose our patients. SMBP is also useful in assessing the effectiveness of the antihypertensive treatments that we give our patients, so essentially monitoring our patients' response to treatment. And it's also helpful for engaging our patients in self-management of hypertension. So again, we'll come back to SMBP a few times throughout the talk today. Next slide, please. So if I had to boil down sort of the crucial recommendations or the key action steps for how to get accurate blood pressure measurements in your practice, I would say that it's these few kind of crucial ideas. First of all, we want you to use validated and calibrated devices. We're going to talk a lot more about that in a moment. Secondly, it's critical to use that correct measurement technique for all the reasons I've already outlined, and to also perform the proper number of blood pressure measurements. We'll go into all of this. But I want to say these three main ideas apply to both in-office blood pressure measurement as well as out-of-office blood pressure measurement, or SMBP. Next slide. And then it is also really critical to make sure that the people who are measuring blood pressure are trained and retrained. And this is important regardless of what type of blood pressure device you're using. So whether that's a manual blood pressure device or a semi-automated or automated blood pressure device, observer training is still crucial. Training should also include skills assessment, and it should include the following components. It should include patient preparation and positioning information, how to select the appropriate cuff size, how to actually take that measurement to obtain accurate and representative results, as well as how to document the measurements in the EHR and communicate those measurements to patients. And the guidelines tell us that we should all be getting retrained every 6 months to 1 year. And then the healthcare team is not the only one who needs to be trained in blood pressure measurement. It's also crucial when we're doing SMBP to make sure our patients are trained in how to measure their blood pressure properly. So we don't want to just tell our patients to go get a device, take some measurements, and let us know what they find. We want to make sure that our patients are getting trained in proper blood pressure measurement by a healthcare professional. Next slide. And so with that, I'm going to turn it over to Linda to talk in a little bit more detail about some of those key concepts.
Thanks, Kate. So as Kate said, yeah, I'm going to add that detail to her information. And so there's different types of devices that we use to measure blood pressure. And one of the first points in selecting device is to make sure you use upper arm devices that have been validated and calibrated. So let's get started. Next slide, please. So the guidelines recommend using validated upper arm devices for obtaining accurate blood pressure measurements. And device validation means the device was tested for clinical accuracy by independent, skilled blood pressure measurement experts using one of the internationally accepted testing protocols. So when selecting devices, make sure that they are validated. Next slide, please. So here's a resource to assist with confirming device validation. There's a U.S. blood pressure validated device listing, which is sometimes referred to as VDL, at the web address validatebp.org. And the website, it'll be updated with additional devices as manufacturers submit their devices for review. And there's also some international VDLs available, and I've got some listed on the slide there. We've included Hypertension Canada website, as well as the British and Irish Hypertension Society and Stride BP. Next slide, please. So devices need to be calibrated. So you need to incorporate device calibration and recalibration into your maintenance schedule. So all devices require calibration at different intervals. So listed here are the guideline recommended calibration schedules for all types of devices. Manual Android devices are easily susceptible to error and loss of calibration, especially when handled harshly. So think about the times you dropped the device on the floor, tossed it onto a desk, or dropped it into a drawer. The normal schedule for manual devices is every 2 to 4 weeks. But things like that, like dropping it, that's going to require the device to be calibrated even more often. And you can see calibration is less frequent for the wall-mounted manual device at every 6 months, and automated devices are calibrated the least frequently at every 1 to 2 years. Next slide. So now we'll start with reviewing the different types of BP devices. And first, I'm going to cover manual devices. So many practices continue to use this method of blood pressure measurement, but the manual method can be inconsistent and inaccurate because results are subject to so many observer issues. There are issues with not inflating the cuff high enough or deflating the cuff too rapidly and not properly hearing the carotid cough sounds. And plus, those sounds are hard to hear if it's noisy nearby or those times when a patient has a faint pulse. There's also terminal digit preference that can play a factor here, and I've got a slide later coming up on that one. But staff always need to be properly trained and perform competencies for measurement accuracy. But with all the observer issues, more focus and time is needed with manual blood pressure measurement methods. Next slide. So blood pressure using semi-automated devices are recommended by the guidelines for BP measurement over manual methods. Semi-automated devices take one measurement after you push the start button and often come all in one and include a pulse oximeter and the thermometer. But the automation makes the measurements not as likely to be affected by variations in technique or human bias and are better able to be reproduced than readings taken manually. So there's no longer issues with not pumping the cuff high enough or deflating the cuff too rapidly and having to hear carotid cough sounds. These devices are considered reliable and accurate when following the guidelines by selecting devices that are validated and calibrated regularly. Next slide. Automated device Automated office blood pressures, they're also referred to as AOBP, and these are the fully automated devices, and they have capability to record multiple BP readings with a single activation. So most are programmed to take 3 readings 1 minute apart, and the device will give you an average of those readings, and you want to be sure to include documenting that average in your EHR. But because the programming ability, readings can be taken unattended, meaning the staff can leave the room after starting the readings and allowing the patient to be alone. So this can actually help reduce a white coat effect. Next slide, please. Ambulatory blood pressure monitoring is also referred to as ABPM. It's an out-of-office blood pressure method. The device is placed on the patient and they wear it over a 24-hour period. And it's going to measure their blood pressure intermittently during the day and night, and while the patient is performing normal activities and while asleep. So it's usually set to take blood pressures, usually 15 to 20 minutes during the daytime, maybe every 30 minutes or just slightly less than that. Or more than that during sleep, so it tries not to disrupt their sleep as much. But the advantage of ABPM is the ability to identify blood pressure patterns and identify white coat or mass hypertension or nocturnal hypertension. And this is important because high asleep blood pressure and non-dipping BP at night correlate with increased risk of morbidity and mortality. And there's some issues with the availability of ABPM because most primary care practice offices don't have one. So likely a referral to cardiology may be necessary. Next slide, please. So self-measured blood pressure, also referred to as SMBP, is when a patient takes their own blood pressure, usually at home. While ABPM is the preferred method for out-of-office blood pressure measurement, SMBP is better tolerated and is more widely available. SMBP is recommended by the guidelines for confirming a diagnosis of hypertension, and like ABPM, can identify patients with white coat and masked hypertension. And several studies show these home measurements maintain a stronger association with cardiovascular disease risk than office blood pressures. Next slide, please. And so now we'll review correct measurement technique. Next slide, please. So accurate measurement relies on how we get patients ready for the readings. You want to educate your patients, as they're coming in for visits, that prior to their appointments, avoid caffeine and exercise and tobacco and other stimulants for 30 minutes before the visit. So you're going to ask them not to drink that cup of coffee in the car on the way and not to have that cigarette and toss it out in the parking lot or by the door before they walk in. But have the patient also empty their bladder if it feels full. And we know there's a lot of activity in clinics, but try to have the patient rest for 3 to 5 minutes in a quiet area prior to the measurement. And if building in a rest period isn't possible, make taking the patient's blood pressure the last thing you do when getting the patient ready for the provider. Next slide, please. So when you measure blood pressure, you want to make sure the patient is positioned for accurate measurement. And this includes having the patient seated in a chair with back support, with legs uncrossed and feet flat on the floor. And if their feet aren't flat on the floor, have them place their feet on a step stool. A cuff appropriately sized for the patient should be placed over bare skin, and the patient's arm should be supported on a table or surface in such a manner that the middle of the cuff is at heart level. Next slide, please. So this table displays the effects of blood pressure results when patients are not positioned properly for BP measurement. So you can see the changes from crossed legs at 2 to 8 millimeters of mercury. Having the cuff too small can affect it up to 10 millimeters of mercury with a full bladder, or with talking and listening and unsupported arm, also all at 10 millimeters of mercury. But most impactful is placing the BP cuff over clothing, and that can affect the blood pressure by 5 to 50 millimeters of mercury. So again, think about the impact of falsely elevated blood pressure readings. We can affect like proper diagnosis. It can affect, leading to over-treatment if we think that blood pressure is really that high. And then we know over-treatment could lead to falls, which we know is an even bigger concern for our elderly population. Next slide. Using the incorrect cuff side is the number one error in measuring blood pressure. Cuffs that are too small give falsely high blood pressure. Cuffs that are too large can give falsely low blood pressures. So as a part of that ongoing staff training and competencies, staff should be trained to measure the patient's upper arm circumference for selecting the correct size cuff for in-office and for patients using SMBP. So staff should use a tape measure to find the midpoint between the acromion process and the electron process. Then you wrap the tape measure around the arm at the midpoint and get the circumference. And when doing in-office blood pressures, there are also reference markings on the cuff that the staff can use to ensure the proper size is being used. And for your patients doing SMBP, they can be taught virtually also how to do that or how to measure their arm circumference at home. Next slide, please. So now that you've selected the correct cuff size, here's some important things to remember when placing the cuff onto the patient. You want to use upper arm cuffs placed over bare skin. You place the cuff so the center of the cuff is at heart level, and wrap the cuff so one finger can fit under the cuff easily at the top or bottom, or two fingers snugly. And usually the tubings align with the brachial artery, but be sure to follow the manufacturer's directions, as sometimes an arrow may be used to line up that brachial artery. Next slide, please. So, every exam room is different, but here's an idea of how to arrange your exam room for accurate measurement. Exam rooms usually are designed with the panel of devices on that wall, and includes the anti-writer manual blood pressure device over the exam table. But the device should be at eye level of the observer. So moving it over by the chair and by a table for arm support allows for more accurate reading. And chairs with armrests can be used for arm support as well, but for taller people, they're still going to need to use a table. And if you can't put the chair by a table or desk, you can consider using the end of the exam table. Just move the chair by the exam table, and at the end, you can put their arm on that or pull out that little footrest, that can also be used for arm support as well. So it gives you like 2 extra levels. And so these are just a few ideas for those who might need to reconfigure their exam rooms. And next slide, please. So we know many health centers rely on manual blood pressure measurements. I just want to do a quick review of the proper steps to take one. So once the patient has the cuff on, you want to palpate the radial pulse, then inflate the cuff until you obliterate that pulse, and then pump up another 20 to 30 millimeters of mercury. And then you're going to place the stethoscope at the antecubital fossa, and then slowly deflate the cuff at 2 millimeters of mercury per second. So most people deflate that cuff much more quickly, so this will take a little getting used to when you start to slow down to the proper speed. The first sound you hear is your systolic blood pressure, and the number when the sound disappears is the diastolic. And palpating that radial pulse ensures that you'll never miss the systolic BP sound, including one with an auscultatory gap. And it prevents you from pumping up unnecessarily high, which can cause the patient discomfort, or from not pumping up high enough and missing that systolic blood pressure. Next slide, please. Terminal digit preference describes an observer's tendency to record the measurement using certain digits more frequently than others. So terminal digit preference has been reported to occur in a variety of clinical and research settings, and up to 81% of the time in some research studies. The BP measurements are significantly more likely to end in 0 than any other digit, and even numbers are generally preferred over odd. I can tell you an example of a practice I worked with a few years ago. They were doing manual BPs. Their terminal digit preference was over 70% with 1 year's worth of data when it was analyzed. And they purchased an AOBP, stopped all use of manual blood pressures, and their terminal digit preference dropped to 21%. So remember, when you use automated devices, the observer bias of terminal digit preference and all the other biases actually will go away. And I will pass it to Taylor now. Thank you.
Thank you, Linda. Next slide, please. Talk about the process for performing initial as well as repeat blood pressure measurements. Next slide. First, we'll focus on obtaining the initial BP measurement. During the first visit for new patients, you should perform a BP measurement in each arm. The arm with the higher BP should be used going forward for all BP measurements. It's helpful to document which arm should be used in the patient's chart. Also consider letting the patient know which arm they should be using for their BP measurement. Remember to use correct measurement technique, properly position your patients, and document the initial reading in a vital signs field in the EHR. Next slide. Now that we've discussed initial measurements, let's go over repeat measurements. A single in-office blood pressure is inadequate for clinical decision-making. 2 or more repeat measurements, 1 to 2 minutes apart, should be taken at clinic visits. These repeat measurements should then be averaged into a single systolic and single diastolic reading. The average should then be documented in a vitals field. Next slide. Here's a helpful tool for averaging blood pressure readings. This is the BP averaging calculator. With this tool, you can add all the confirmatory BP readings and it will calculate them into a single reading for you. Next slide. Once your initial and repeat measurements have been taken and documented, the provider should be notified of any high BP readings. Standardize the method used for notifying your providers of high BP readings, whether verbally, EHR alerts, a visual cue on the patient's chart or exam room door, or a combination of all these. Next slide. Now that we've covered in-office measurements, let's dig deeper into self-measured blood pressure. Next slide. We'll start by diving deeper into self-measured blood pressure, or SMBP. As we mentioned earlier in the presentation, SMBP is when a patient measures their own blood pressure outside of the clinical setting. When performed using an evidence-based measurement protocol, SMBP provides a more complete picture of a patient's blood pressure because multiple measurements are performed daily over the course of a week. SMBP allows care teams to see what the patient's BP is outside of the clinical setting. For these reasons, SMBP is better able to predict future cardiovascular events than a single in-office BP, which just provides a small snapshot in time of a patient's blood pressure. Excuse me. SMBP has been shown to improve blood pressure control and lower BP when combined with clinical support and co-interventions such as patient education and medication management. Once a patient is identified as someone who would benefit from SMBP, it is important to confirm that they have a validated device with an appropriately sized cuff. When possible, patients should use an automated, validated upper arm cuff to self-measure their blood pressure. As with in-office, validation refers to the process in which a device is tested for clinical accuracy. Patients must also select the SMBP device that has an appropriately sized cuff based on the mid-upper arm circumference. Home BP devices usually have cuffs that cover arm sizes from 8 inches up to about 14 to 18 inches. XL cuff sizes are available for some devices, but you'll have to check with the manufacturers to be sure. Next slide, please. Once an appropriate home device and cuff size have been selected, patients must be trained on completing SMBP. So first we'll look at proper preparation. Similarly to in-office measurements, in order to properly prepare a patient for self-measurement, they should avoid caffeine, tobacco, exercise, and other stimulants for 30 minutes before the measurement. If they've recently eaten, they should wait at least 30 minutes between the time of the meal and the measurement. Patients should also have their bladder emptied and perform SMBP measurements before taking their antihypertensive medications. Patients should find a quiet place where they can rest comfortably and avoid distractions. Instruct patients on how to use the device and how to properly place the cuff on their designated blood pressure arm. Next slide, please. Once the patient has designated a quiet area, they should place the cuff on their bare upper arm and properly position themselves for the measurement. To do this, they should sit in a chair with their back supported, their legs uncrossed, feet flat on the floor. Their arms should be supported on a table or armrest with their palm facing up. The middle of the cuff should be at heart level. Patients should rest for 5 minutes before starting their measurement. There should be no distractions during the measurement. Patients should be informed of how often and when to measure their BPs. They should also know how they will record their readings and share them back with the care team. Patients should be instructed to take 2 sets of measurements twice a day, 1 set in the morning and 1 set in the evening. Each set consists of 2 readings performed 1 minute apart. This is ideally done for a week with a minimum of 3 or 12 readings being required for clinical decision-making. Ensure that the patient understands all the information that has been provided to them. Next slide, please. Once the patient has completed all readings, they should share them with the care team. The care team should average the readings into a single systolic and single diastolic blood pressure, which should be used for clinical decision-making. The averaging calculator discussed earlier in this presentation can be used to assist teams with this process. Again, remember, 3 days or 12 readings are required for clinical decision-making. Documentation of the average systolic and diastolic blood pressure should be in a defined SMBP field if one is available. Using a delineated field helps ensure access to the information by all care team members. Again, the average will be used by the providers for making clinical decisions, so it's critical that they know where to find those results. The provider should be notified that the results are available for review, and once the provider has interpreted the results and determined the treatment and follow-up plan, the patient should be contacted with their next steps.
All righty, well, that concludes the video portion of our the training, and an excerpt that can be found in the Watch Party Toolkit. So that gives you a flavor of some of the substance. There's another section that talks about some of the tools and resources that are really helpful, but it gives you just a flavor of what can be shared with your care team. So what I'll do is I just want to move on here with an example of another poll question that can be used. There are many others in the toolkit to draw from. The first one that we asked you was a little bit more about training cadence. This has to do specifically with the information around blood pressure devices, and asking you how you ensure that your blood pressure devices are accurate. And you can select all that apply here. Whether you purchase devices that are listed on the validated device listing, you calibrate if you have wall-mounted devices every 6 months, you calibrate handheld Android devices every 2 to 4 weeks, or you calibrate your oscillometric devices usually every 1 to 2 years or per manufacturer's instruction. You might not be sure, or that you don't currently have a plan to address blood pressure device accuracy. So this is just another example of a poll tool to incorporate into the training. So it looks like we have a handful of respondents here. Appreciate your responses. Just wait a few more seconds because their multi-selects take a little while longer. All right, in the interest of time, I'll share the poll results, and it looks like a variety of practices that certainly depends upon the devices that you have in your practice. So I'm gonna close that poll and move on just to with a few more items before our session concludes here. Just pausing for any Q&A, both about the clinical content that was shared, but also about the toolkit itself. I'll make a few comments here. I don't see any questions in the Q&A or the chat at the moment. We certainly encourage you to raise your hand if you'd like to speak up and make a comment, and our tech team will unmute you, but I'll just say a few things about the clinical content. You can see here, when I think about accurate blood pressure measurement, there are three things that are really important. The analogy I use is when you want to take a safe journey, you need a safe car, you need a safe driver, and you need a safe road to get there safely and completely. And in the analogy for blood pressure, the device is the car that has to be accurately, an accurate one purchased to begin with and then maintained for its accuracy. The safe driver is our care team using proper technique for every patient, every time. And the safe road is the care process, the care environment, the exam room setup, the documentation and protocols that you have in place to consistently perform that function for every patient, every time. So hopefully this training is something that you can imagine using either in parts or in total with your team. As far as the toolkit itself goes, obviously the educational benefit is there to strengthen knowledge. There's also the opportunity to do skills testing, and I'll just flip forward 1 second here. There's a technique quick check tool that can be used to test your team to ensure that they have accurate, ensure that they have accurate skills, and you could either do a peer review and assign folks to observe one another, observe either in a competency testing approach or observing people in practice, which is even more effective. Let me just back up here. And the other benefits are obviously around target BP recognition, and I'll talk about that in just a second. In terms of the program itself, we will encourage all of you to provide evaluation using a link that will come in the chat here shortly, and also in the follow-up email. We really love your feedback as a participant in this type of training. And then there are also steps that we outline in the toolkit and that you can follow also after today's program to claim the Enduring CME and CE credit. This activity is housed on AHA's Lifelong Learning website. If you have an account there, you can sign in and just launch this activity and claim the credit, attesting that you've seen the content through this activity. Or if you don't have an account, it's a simple setup, and it's free to set that up. And then you can claim your credit, complete the steps, and print the certificate. And that's one of the ways that if you have your staff engaging in that activity, it helps validate that they've completed those steps. Let's see, I'm just double checking to see if we have any other questions or comments. I certainly invite those. I will, if the moderator wants to interrupt me with anybody who's raised their hand, I certainly invite that. In the meantime, I'll just cover a few other things before wrapping up. Obviously, this resource was designed also to support your advancement in the target BP recognition program. As you recall, there are three main categories within the evidence-based blood pressure activities that contribute to the silver or the gold plus recognition, where you can attest to at least 4 of these 6 activities. And items 3 and 4 on this list are what we've addressed here today: strengthening knowledge and skills of staff every 6 to 12 months, and then the opportunity to test their skills and see if that knowledge has been translated into practice. And again, every 6 to 12 months. And that's an activity that has to occur every year, every recognition cycle, essentially, to qualify those activities as part of your award attestation. And then, as I mentioned, here's an example of that testing tool. So I'll just pause here again and see if there are any other comments or questions about the Watch Party toolkit, or any other comments or questions about accurate blood pressure measurement. I'm not sure if there are any other hands raised. Anything else in the Q&A or the chat? Happy to address those.
I don't see anything in there as well.
All right, well, I'll give you a few minutes back today in between, and I hope you enjoy the rest of the program. Thank you all for your time and attention and what you do every day to measure blood pressure accurately and improve hypertension control. Thank you so much.
Thank you very much, Allison. Really appreciate what you did. I think that this is something going forward that organizations can use to really help train their providers. So thank you so very much. At this point, what you can do is leave the session and go back to the main room to listen to Dr. Churchwell's presentation. Thank you so very much and have a great day. You will also be able to, after this session, we are going to be presenting the awards for Toolkit BP. Thank you.